Hello and welcome back to Curbside Ethics. I'm Dr. Stephen Bradley, your host. I am an anesthesiologist and clinical medical ethicist. The goal of this podcast is to empower the listener to make better ethical and equitable decisions for the benefit of their patients. In this episode, I am imploring clinicians everywhere to stop unilaterally revoking DNR, DNI requests prior to patients going to the operating room. This is a situation, a topic that comes up not infrequently, especially in healthcare as our patient population continues to grow older, as there's more education on options towards the end of life and patients are empowered to make these difficult decisions. It's something that's going to continue to come up and is going to reach across specialties. And I'd be surprised if most of us, regardless of medical specialty, don't have some interaction with a patient who's DNR, DNI and coming to the operating room for a procedure. In some circles, there may be some bias or room for education. If perhaps you're on the medicine ward team and your patient needs a surgical procedure, sometimes there's room for education. Maybe you don't realize that just because they're DNR or DNI doesn't preclude them from having a surgical procedure. I see this frequently from my surgical colleagues as well as from other anesthesiologists, where there is, again, a room for education because their knee-jerk reaction is to, okay, patients coming to the OR, we need to suspend the DNR, DNI. Bottom line up front, we should no longer be unilaterally revoking DNR, DNI for patients. Instead, we should be having conversations with these patients and understanding their wishes regarding end-of-life care and contingency plans and what are their concerns, what do they want to avoid, and ultimately work together to develop a plan to proceed and to navigate circumstances if their heart were to stop, if they needed a breathing device, etc. For the specialists that don't work in the operating room or that don't actually provide anesthesia, having confidence and be able to discuss with your anesthesiologist what their plan is, or know that we're able to have that discussion with patients, may provide some additional comfort and prevent that moral distress of being concerned about a patient's wishes not being honored. The American Medical Association is a journal of ethics, and this is a fantastic resource. Back in March 2015, they actually had a whole journal article dedicated to anesthesiology and surgery. And this is an article coming from that resource, March 2015. The article was entitled Perioperative, Do Not Resuscitate Orders. Essentially, when it comes to breaking down this topic, number one, what you need to come away with from this episode is that we're going to stop unilaterally suspending DNRs prior to the operating room. Looking back in history, in the 1990s, the United States Congress passed this Patient Self-Determination Act, and this was in response to concerns that there was still a fair amount of authoritarianism and paternalism in the healthcare field when it comes to helping patients make these decisions about life-sustaining therapies. With this Patient Self-Determination Act, this required patients to be informed of their rights to consent to or to refuse different medical therapies. This law initially focused on the patient's rights to refuse medical treatment, including life-sustaining therapy. Without the opportunity for informed refusal, there can be no informed consent. I'm going to say that again. Without the opportunity for informed refusal, there can be no informed consent. Sometimes that's discongruous with what we think as physicians and healthcare providers that, maybe this is going to trigger an evaluation of patients' competence or capacity because they're refusing to go along with our treatment plan. But realize that patients are allowed to refuse treatment, assuming they understand the risk, benefits, etc., just as much as they're allowed to consent to treatment. Realize that the Do Not Resuscitate order, or the DNR, is a medical and legal document that reflects a patient's decisions and desires to reject life-sustaining interventions in specific circumstances. These patients can forego different resuscitative procedures and the possible benefits associated with those procedures because they also reject the possible burdens that are associated with them. The topic will be too broad to go into why different patients request DNR, DNI, maybe another topic for a different episode, but accept that for whatever reasons, this patient has the autonomy and this is what they feel like is right for them and in line with their goals of care. Sometimes these complications that come from resuscitation, we know you can have fractured ribs, long-lasting cardiac dysfunction, decreased mobility, prolonged intubation. All these things can still occur despite a quote-unquote successful resuscitation. A lot of patients that have these DNR orders are coming to the operating room for other procedures. Sometimes these procedures are palliative. Sometimes these procedures are urgent emergent or will allow the patient to regain or remain alive with that current quality of life. These procedures are tracheostomies or placing of a surgical breathing tube, gastrostomies, a G tube or a feeding tube essentially goes into the stomach, maybe large bore IV access placement, or pretty commonly patients are coming in for hip fractures. These are your older deconditioned patients that have fallen, maybe they have cancer or a pathologic fracture, and they have a broken bone. This bone needs to be fixed. If you fix this bone and everything's successful in surgery, or if you fix this fracture, rather, the patient could continue on to live that same or very similar quality of life. However, if you don't fix it, this patient will die from this injury. Historically, DNR orders were suspended during these procedures. Just unilaterally, if you're coming to the operating room, you're no longer DNR, DNI. Dr. Robert Trujag, he is an anesthesiologist who's done an incredible amount of work in this field of informed consent and medical ethics. The year after Congress passed this Patient Self-Determination Act, this was back in 1990, so 1991, 1992, Dr. Trujag wrote a paper analyzing the routine management of existing DNR orders for patients that were coming to the operating room for anesthesia and or surgery. He brought attention to the fact that if we automatically suspend DNRs, we are, one, violating this new federal act, and then we're also disregarding patient autonomy. Dr. Trujag noted in his work that it is obviously unpleasant and sometimes uncomfortable to provide anesthesia care for patients with a DNR order. And as an anesthesiologist, these anesthetics are very tedious because there are significant stakes involved. Not that there's not a lot of stake involved with every patient we provide anesthesia for, but navigating these situations are indeed tricky. Patients who have DNR orders in place, they're usually in the terminal phase of their disease. These patients are sicker. They're not coming usually for elective procedures. They're all usually indicated for some reason. They're likely more susceptible to the adverse effects of anesthesia and the surgical procedures. Many clinicians, though, feel it is inappropriate for a patient to die as a direct result of an anesthetic complication. It does not feel good as the anesthesiologist or surgeon to bring your patient to the operating room and to have that patient expire under your care. However, Dr. Trujag noted, even if a life-threatening complication is iatrogenic or caused by clinicians, this in and of itself is not a reason to override a patient's DNR order. Dr. Trujag goes on to argue that several aspects of anesthetic treatment justify suspension of Do Not Resuscitate orders during surgery, but the specifics of these suspensions must be individualized and discussed with patients. General anesthesia or sedation can result in your anesthesiologist needing to resuscitate you because we have depressed your vital signs, we've depressed your heart, and your blood pressure is lower, your heart rate may be deranged, and it will require some amount of resuscitation. Anesthesiology in its purest form is a state of active resuscitation as we provide anesthesia. So that in and of itself will be discongruous with a Do Not Resuscitate order. Terminally ill patients are usually very sick. They may have some degree of physiologic dysfunction. Just age alone changes the way the physiology works in the body, something that we compensate for as anesthesiologists. These patients are at risk for hemodynamic or pulmonary instability or collapse. And it's difficult to differentiate our resuscitation of these patients, whether it's different from your standard anesthetic or if it's more because of their physiologic dysfunction. Informed consent for anesthesia includes a consent to the full benefits of a standard anesthetic practice and is in effect, you're consenting for resuscitation along with the anesthesia. And it's likely inconsistent with the continuation of an existing Do Not Resuscitate order. So what does that mean? Does it mean we need to unilaterally rescind this DNR? No, it doesn't. It just means we need to have more of a conversation with these patients about what is going to occur. Some patients that come to the operating room with an existing DNR, they may prefer an attempt at resuscitation after an arrest based on the judgment of the clinicians. There's a much greater likelihood of successfully reversing a cardiac arrest when it occurs under anesthesia or in the operating room. These arrests are witnessed. The etiology or the cause it's a very narrow list, and we're able to navigate that. And we have fairly good outcomes depending on the etiology. Dr. Trujag states in his paper that every arrest that occurs under anesthesia must be considered the result of an intervention and thereby potentially reversible until proven otherwise. These topics should be discussed with patients individually as opposed to being dictated by institutional policy. This question of whether spontaneous and or iatrogenic cardiac arrest should be handled differently should be factored into that pre-anesthetic discussion about whether to retain the existing Do Not Resuscitate order. From the patient's point of view, the cause of the arrest may be irrelevant because it does not significantly change the factors that prompted them to request not to be resuscitated. Perioperative functional status and the threshold for further burdens while dying is what goes into those Do Not Resuscitate requests. So those don't change no matter the type of arrest and the success rate of resuscitation. Communication is key. Both the anesthesiologist and the surgeon or proceduralist need to discuss amongst themselves with the operating room team as well as with the patients the potential for mishaps to occur under anesthesia, discuss with the patients the potentially prolonged effects on their physiologic status. Typically, the anesthetic effects resolve after a couple of hours, and at that point, no further resuscitation or physiologic support should be needed. That patient can return to that full DNR, DNI status. However, with respiratory function, the breathing device or breathing tube may stay in for longer than anticipated. It's hard to know ahead of time. With that, discussion can be had of ventilatory support being continued as long as there is evidence of sustained improvement in pulmonary function. That is some verbiage that you can use to discuss it with patients. Bioethicists unilaterally reject that notion that it is better to withhold care than to begin care and then withdraw it. Know that there is this uniform agreement. Withdrawing and withholding life support are morally equivalent. I'm going to say that again. Withdrawing and or withholding life support are morally equivalent. So you're not out of the woods just because you say, well, I don't want to be the person that contributes to this person's death. I'm not going to offer this modality. If you think it's reasonable, you need to have a discussion with the patient and you can come to an agreement together. This does not supersede, physician autonomy as well, because we do have that judgment. Although existing DNR orders may not be applicable or ethically appropriate during surgery, we should maintain these robust pre-anesthetic discussions. We need to personalize these decisions about resuscitation-related matters instead of imposing this one-size-fits-all policy for our patients. In 1992, so remember that first legislation came out in 1990. There's a good paper in 91 by Dr. Trujag. In 92, the American Society of Anesthesiologists reestablished its Committee on Ethics, and their first task was to develop an opinion and guideline related to this matter. Within a year, they produced the ethical guidelines for the anesthesia care of patients with Do Not Resuscitate orders or other directives that limit treatment. This was adopted by the American Society of Anesthesiologists in 1993. And currently it states that policies automatically suspending DNR orders may not sufficiently address a patient's rights to self-determination in a responsible and ethical manner. These policies should be reviewed and revised. Subsequently, these guidelines regarding DNR orders were adopted by the American College of Surgeons as well as the Association of Operating Room Nurses. So all three of these professional organizations now are advocating for the fundamental right of self-determination for competent patients to define and limit what treatment will be provided to them in the operating or procedural suite. Based on these guidelines, there's two options for patients with an existing DNR. The patient can opt for a full attempt at resuscitation, thus suspending any existing DNR directive during the procedure and a defined duration afterwards. It's important to talk about how long is this DNR going to be suspended for. If the patient, however, decides to reject a full suspension of the existing DNR, he or she could choose a procedure-oriented, limited attempt at resuscitation and indicate what procedures this would entail. By completing a checklist of sorts, patients could designate which specific resuscitation procedures they would permit or reject. chest compressions, defibrillation, intubation, mechanical ventilation, fluid resuscitation, etc. It goes on and on. While offering the advantage of avoiding some ambiguity by describing what resuscitation functions are permitted, this procedure-oriented approach fails to address the context-dependent procedures or preferences that the patient has for their own desired outcome. If all we have is a checklist of what the patient does or does not want in regards to resuscitation, then we have incomplete information about how to implement the information in the checklist. During these conversations with patients, we need to determine what are their long-term goals. In 1998, the ASA Committee on Ethics revised these guidelines to incorporate this third option, a limited attempt at resuscitation with regard to a patient's goals and values. And that is the key right there, the patient's goals and values. Patients should now be able to define rather their desired perioperative resuscitation in terms of outcomes rather than procedures. This leaves more decisions about specific resuscitative procedures to the anesthesiologist and the surgeon's judgment. The context of a cardiac arrest or hemodynamic deterioration could now play a more significant role in determining the clinician's response. Although this option gives the anesthesiologist an enhanced understanding of the rights of autonomous patients, it also imposes a pragmatic and ethical requisite upon the anesthesiologist and the surgeon or proceduralist to understand a patient's values and objectives. Again, it's a longer conversation than we otherwise would be having. This third option is challenging and it's difficult to navigate for your typical anesthesiologist. It's difficult to have these discussions about discomfort and death and dying with these patients, especially when you have a limited amount of time to build rapport with the patient, to get to know this patient before they're off to surgery. Today, the production pressures in most anesthetic practices are ridiculous. The opportunities presented by this option, however, you are able to question whether a patient's right to self-determination is best honored by a goal-directed process that has potential to introduce rather than eliminate ambiguities and decisions about the therapeutic interventions. Despite these concerns, the ethically appropriate preoperative DNR discussion relating to a robust informed consent process is one that achieves, as far as is practical, a fully informed patient decision and consent by clarifying the three options and making them well understood. These patients typically have highly specific goals and objectives, the reason they're coming to surgery, whether it's palliation of their distressing symptoms. They also know why or would they want benefits of the procedure only when certain burdens, such as a lengthy postoperative ICU stay or living with further decline in cognitive or functional capacities, are not placed upon them. To prevent these conflicts, not only the anesthesiologist, but also the surgeons and operating nurses, the entire team must agree beforehand about how to manage these ethically, psychologically, and emotionally perplexing scenarios. There's always a concern about legal action. Standard of care and accepted practices of communication, collaboration, documentation provide protections if you adhere to these properly executed DNR orders. Technically, an unwanted physical intervention does constitute battery. There's instances of physicians, nurses, hospitals being found culpable when patients have been resuscitated against their wishes. Overall, it is the most prudent to act ethically by honoring an informed patient's directive. Taken from Dr. Trujag's initial article, ethical analysis rarely provide concrete solutions to complex medical problems. At best, it clarifies the relevant issues and delineates areas of conflict. Traditional medical practice responds individually and compassionately to the unique needs of each patient. Policies are designed to promote uniformity and generally are not well suited to situations that depend heavily on individual preferences or values. Rigid policies related to the management of DNR orders during anesthesia and surgery would restrict rather than enhance the options of patients and physicians in facing this difficult issue. With the increasing recognition of the autonomy of the competent patient in medical decision-making, it will be inappropriate not to seek the patient's guidance and provide as much latitude as possible within the constraints of the physician's own ethical standards. This is a fantastic paper that kind of breaks down a lot of the issues involved with navigating DNR, DNI, and patients. I'm going to speak a little more specifically and provide some actionable information when it comes to a DNI, Do Not Intubate order. For some surgeries, an anesthesiologist can provide an anesthetic without intubating the patient. There's different modalities, whether we're doing sedation, whether we're able to do a regional approach or an neuraxial approach, such as a epidural or a spinal. We can proceed without intubating the patient. Again, this is covered in an informed consent discussion as we delineate this patient's goals of care. Unfortunately, a lot of these patients that are coming to the OR for hip fractures, which would be very amenable to a neuraxial approach, a spinal or an epidural, have other problems, whether it's a compromised aortic valve, whether they're on anticoagulation, which means at the very least, the discussion involves if we're not able to place a breathing tube, then we can wait several days for the blood thinners, the anticoagulation to wear off, and now we can safely perform a neuraxial approach, and that avoids having to intubate. Once again, there's a risk benefit to that because being off of your anticoagulation may increase your risk. But know that sometimes there's a way to proceed without intubating. If it's a laparoscopic procedure, the patient's going to need to be intubated, and it's a hard stop. I will respect your autonomy. However, if you refuse to be intubated for this procedure, I am not able to safely provide an anesthetic. When it comes to resuscitation, I attempt to provide that third option where I talk with the patient and understand what are your goals of care, what are your priorities, and the qualities that you deem important. I approach this conversation head on. I talk to the patient. I perform my typical history physical exam. Typically, these patients in my hospital system are wearing a bracelet that denotes their DNR, DNI status, and I bring it up. I was looking over the chart. I see you have that bracelet on, indicating that you would not like to be resuscitated or intubated. Do you mind if we discuss that further? During that discussion, I say, well, what are your specific concerns with resuscitation or with intubation? What are your goals? What are your thoughts on end-of-life care? And then I go through the things that can happen with anesthesia. And I tell them that during anesthesia, I am actively resuscitating most patients, and I would be giving medication through the IV to maintain your blood pressure, to maintain your heart rate. Is that in line with your wishes? Okay. If your heart were to stop, or if you were to stop breathing, would you want me to continue to provide chest compressions and or electric shock? And I kind of discuss that. I still go through a bit of a checklist to make sure that there's nothing that is kind of discongruous with the overall picture, right? Because patients still have autonomy, even though they may not fully understand the difference between resuscitation and chest compressions and how that fits to their end goal. But some patients just absolutely are opposed to certain aspects of resuscitation. And I do my best to accommodate or at least have a conversation about that. Lastly, when it comes to your physician colleagues, whether you're a surgeon, whether you're an internist, whether you're an anesthesiologist, you have to have conversations with your fellow physicians, because a lot of folks are still practicing that old school where you just unilaterally suspend that DNR, DNI, and realize that this is now more of a nuanced conversation. Make sure that all the stakeholders are involved. Make sure you include the operating room staff, whether it's the techs, whether it's the OR nurses, the circulating nurses. And what does that look like? Me, when I'm working, I will see the patient. If I see the surgeon beforehand, I'll say, hey, doc, you know that she's DNR, DNI. I'll have a conversation about it unless you have, do you know the patient's wishes? And they may or may not have had that conversation. I go have a conversation. Typically, the patient says, that's cool, doc, do whatever you need, or they have a concern. Then I come back to the surgeon, I come back to the operating room nurse and say, hey, this patient's DNR, DNI, they're okay with being intubated for this procedure, or they're okay with resuscitation through the recovery period. And I just make sure everybody's on the same page so they know that, one, I had this conversation, and two, this is the plan for what we would do. And even though, this might be a colonoscopy or some other procedure where it's benign, is fairly low risk, I always endeavor to have this conversation because it's better to have it up front than to be in the middle of a procedure when something goes wrong and then you're kind of trying to figure out how to do what's right for this patient. If you gain anything from this episode, hopefully you learned something. You can take this with you, share with your colleagues. Visit us on iTunes, where you can like this episode. You can leave a review, leave a rating. That really helps the show to grow. I love feedback. What are your thoughts about DNR, DNI, and how do you navigate this in your practice? Visit my website, StephenBradleyMD.com, where you can leave a comment, or you can ask me questions, whether it's about military medicine, medical school, or medical ethics. Happy to help in any way I can. Thank you so much for tuning in to this episode of Curbside Ethics, where the goal is to empower you to make better ethical and equitable decisions for the benefit of your patients. Curbside Ethics is written and produced by me. The theme music is performed by me, Stephen. If you enjoyed Curbside Ethics, please tell a friend about the show or share a link on social media and leave a review on Apple Podcasts. There's no team behind Curbside Ethics, it's just me. And I can use all the help I can get growing this show. To learn more about the podcast, follow my Instagram page, Stephen Bradley MD. I am also on Twitter and LinkedIn. You can also visit my website to submit topics or questions regarding medical ethics. That's all for today, and I'll talk to you next time.